صباح الخير والله يعطيكم العافية جميعا. Good morning everybody. So we're going to start the first day of the conference. We're going to start with actually interesting session which is nightmare. I hope nobody sees such a nightmare. So we will start with Dr. Ahmed Al-Harraz from Al-Mansoura University. He's working at Al-Farwaniya Hospital currently as senior consultant. He will be talking about bladder perforation during transurethral resection of bladder tumor. The podium is yours now, Dr. Harraz.
Okay. Thank you so much for giving me this opportunity. So I'm going to speak about perforation during TURBT. Actually, I think from my point of view, it is a very important topic because it is encountered, it is not uncommon in our clinical practice, especially we have a lot of cases of TURBTs. So the first of all, the overall incidence is quite low. It's 2.5%. But when we look at the studies that examine the incidence, when the residents are the main surgeons, we're going to find that 50% of residents experience this. They could induce perforations during their resection time. And they have an odds ratio of 3. This means that when a resident holds the resectoscope and starts doing TURBT, there is a 3 times more likely chance that he perforates the bladder compared to a senior one. When we go to the causes, there are 3 main causes that can cause perforations during TURBT. The first one may be related to the resection itself. When you cut, when you fire, there will be a full thickness cutting of the wall of the urinary bladder. The second one might be an obturator kick, and the third one, which goes usually unnoticed, which is overfilling and over-distension of the bladder that might cause rupture of the bladder during the procedure. There are 3 main risk factors, and I'm speaking about what is evidence-based, what has been proved in terms of systematic review and meta-analysis. The first one, whether we use, there is a difference in the incidence between monopolar versus bipolar diathermy. When I use either monopolar or bipolar, should I use obturator nerve block or not for lateral wall tumors? And the third one, when we have the laser, introduction of the laser into the field, does it decrease the incidence or not? So the first meta-analysis comparing bipolar versus monopolar, I am quoting the most recent one to the best of my knowledge. It shows that obturator nerve reflex was not significantly different between monopolar versus bipolar. But when we come to the incidence of bladder perforation, no, bipolar is proven better. There is less chance to have a perforation with bipolar diathermy versus monopolar diathermy. So this is the first factor. The second factor, if we are using obturator nerve block, does it change the incidence of obturator nerve reflex or bladder tumor? These are 2 recent meta-analyses that showed that significant reduction in the incidence of obturator nerve reflex and the bladder perforation when we add obturator nerve block with the spinal anesthesia. Okay, with the introduction of the laser, for resection of the bladder tumor, we can find that the incidence dramatically decreased, either for the obturator nerve reflex or the bladder perforation. This is, of course, intuitive because during laser we use saline and there is no electric current at all, so there will be no, we will eliminate the chances of having deeper perforation or obturator nerve reflex. This is also this year, the meta-analysis that has been published this year, showing the incidence of the obturator nerve reflex is 0.4% and the perforation is nearly undetectable. So, of course, if you have a laser fiber, so you're going to go and do the TURBT with this. In terms of diagnosis, the only and the main diagnostic method is either intra or post-operative is CT cystogram. CT cystogram will show the contour of the bladder, the site of the leak, and we can manage accordingly. This slide actually shows all the reported lines of treatment for bladder perforation, either intraoperative or post-operative. As we can see, there is no consensus at all for which category for which patient. What is the modality for each patient? It should be individualized because the management starts from only urethral catheter and keep it to heal spontaneously. Or we can do extravesical drainage like tube drain, intraperitoneal or extraperitoneal. We can go and explore either by laparoscopy or by open surgery to repair the bladder. And interestingly enough, I couldn't find a clear evidence from the literature for immediate cystectomy at the time of TURBT. So this is, from my point of view, most likely because of under-reporting of this. So because no one would like to say that I'll explore the patient, do immediate cystectomy at the time of the TURBT. However, it is still an option. So after we have an overview, I'm gonna show you 3 examples for difficult cases I have faced. So the first one, this patient was referred to me for third look TURBT because there was no muscle in the biopsy. So when I get in, this is the area of the previous resection. I am doing regular scan after this is the third look, and we can see here this unfortunate event, this perforation. So so I did actually complete resection, and I would like to advise when you start the resection in the regular way, we fire usually before cutting. I don't fire when I am touching the mucosa, because if I fire when I'm touching the mucosa, this will increase the incidence of perforation. So we can just fire, and at any time, the part of the loop should be seen to be able to estimate the depth of the cut. If the whole loop was hidden behind the tumor, it will be very difficult to appreciate the depth of this. This patient turns out to be muscle invasive disease, and we did for him radical cystectomy. The second case here, this is an example of when you are touching the mucosa, this will induce a tumor. Usually in large and big tumors like this one, we couldn't appreciate it antegradely, so we prefer to do it in a retrograde fashion. So if you fire while you are touching the mucosa, this will increase the chance of having perforation. So never fire the energy while you are touching the mucosa. You have to fire away from the mucosa and then to start to cut. In this particular case, because of the tumor was really big, we tried to do it in a retrograde fashion. As we can appreciate also, we can deflate the bladder a little bit to not be much stretched so that we decrease the incidence of perforation. Another good tip also is that when we fire, we can use intermittent firing, not continuous firing. This intermittent firing will decrease the chance of having a perforation during TURBTs. It's very important. So either while you are doing it in an antegrade manner or retrograde manner. After we complete the big bulk of the tumor, we can start now resectioning in an antegrade fashion that will make it easy. So by this way, we eliminate the incidence of obturator nerve click or bladder tumor while we are using the loop. This third case, this is actually a big tumor also, which is at the dead lateral wall. And we start again with the same principle. We started in a retrograde manner with intermittent cutting. So we lift the tumor up and we start to fire. Usually we have to use an intermittent firing while we are cutting the tumor. This will decrease the incidence of the obturator kick. But this was unfortunate in this patient actually. This, for example, this is a continuous cut. It shouldn't be done like this because we are at the lateral wall. This continuous cut will increase the chance of having an obturator kick. As we can see, we will lift the tumor with the beak of the scope and then we push, but with intermittent cutting, not with continuous cutting. This is particular for this difficult case. We will proceed together. We can see here when we fire at the left lateral wall, that's it. This is an obturator kick, and we can see it in front of our eyes, how it goes in and the perforation happens. So at this particular case, we will shift directly for the magic solution for this, which is the laser fiber. The laser fiber has a fire end, so you can do resection safely with controlled cuts and while eliminating any incidence of obturator nerve reflex or perforation. We can cut continuously, use the beak of the scope to lift the tumor up and continue cutting. So, and after that, everything should be safe and fine. So, as a take-home message, I advise that if you are in a training, you can start using, during TURB, the cuts. You fire before you touch the mucosa, and you frequently evacuate the bladder. Use deflated bladder. You can use general anesthesia with neuromuscular blockade. However, there is no clear evidence in the literature for using that. The clear evidence in the literature is used for obturator nerve block with spinal anesthesia. And I hope that this will be fine.
Thank you.
Okay, thank you.
I have a question for you, a question for the audience. Is there any literature about the difference between any block resection and the regular classic technical resection in terms of the perforation rate?
In block resection is better than cutting resection. This is current evidence of literature. But I'm not aware of the incidence of perforation with both. Mm-hmm. But the idea is that in block resection, you are more controlling the depth of your cut. Mm-hmm. Whether you are doing it retrograde with a resectoscope or with the laser fiber.
So are we minimizing the risk of perforation?
Yes.
Okay, thank you very much. My question for Professor Abu Al-Ainain, if you may. Is it necessary always to do cystogram if you suspect perforation?
It is not absolutely necessary in every case, but you have the clinical sense that abdominal gardening and pain, distension, and you can see what is the evidence of extravasation in. And if the general condition of the patient is stable, you can just follow for a couple of hours. If the increase of inflow and decrease of outflow, you mean that there is free leakage of the irrigation into. So this means that you have not necessarily to do a cystogram in every case. You can fix a tube drain after doing aspiration and prove that there is an intraperitoneal fluid inside. In case of suspicion, you can, if you have a C-arm in the theater, just you can do gravity cystogram to make sure that's for medical legal issues. But it is not necessary in every case.
For the sake of time, I just will open the question for the audience, if anyone has a question or not. Dr. Bulbul, do you always, put Foley catheter and wait on the patient, or go immediately for considering repair?
You might have to open the patient actually and repair him if it's a big intraperitoneal. I use general anesthesia with muscle relaxant for when I suspect I have a lateral tumor and the obturator kick is going to come in. The obturator block somehow did not work in my hands. Be careful. Another thing you can do is you can resect and the base maybe take a nice cold cups from that deep muscle that you can control the depth more than your loop.
Thank you, Doctor. For the sake of the time, we'll keep the questions at the end. Thank you, Dr. Harraz. Now we welcome Dr. Rohit Joshi to talk about nightmares in endourology. He is an alumnus of Institute of Kidney Diseases and Research Center in India. He is a joint secretary of Ahmedabad Urology Association. He has experience in more than 5,000 laser endourology procedures, including HOLIB and other endourology procedures. Please.
Thank you so much, Mr. Chairman, for warm invitation. And I once again express my gratitude for this opportunity and kind invitation to KU and AAU leadership. Thank you, Hussein, a good friend of mine. I must congratulate the leadership for having this kind of session, because whenever we come in conference, we always talk about positives. We always go gaga about our success things, and then that success story is people take home back, and then they never understand what the journey was full of nightmares, full of failures, and it is the failure that teaches us more than the success. So accept my congratulations for having such a meaningful and relevant session. That's nightmares in urology. My friends, I have this disclosure, but there is no conflict of interest. Yes, I do believe TURP is still gold standard, no debate, but I also believe that HOLEP has grown over TUR being size independent gold standard. I have experience of more than 2,000 enucleations for last decade. I still do 20 enucleations a month. So when we do this many surgeries, we are bound to get some nightmares during the journey, and I also had my share. Today I'm going to open my complication galore. It takes a lot of courage to share these complications with you, but that's in the good faith, because I want you guys to learn from my complication, because good surgeons learn from their own complication, while great surgeons learn from others' complications. So today, my job is to make all of you great surgeons in a lighter way. You're all great surgeons. So I have divided this nightmares into two kind of categories: intraoperative and postoperative. Intraoperative, we can have surprises, untoward events of enucleation or morcellation. Let's take first the intraoperative surprises. These are not the surprises like pathological surprises. You're taking a HoLEP, you're getting stone, you're getting stricture. No, this is regarding anatomical variations which you come across. The first thing is unfriendly urethra. This was, mind well, this was a 22 French mini HoLEP assembly, and I am not able to negotiate my assembly beyond that bulbomembranous junction. And the moment I do it, I did injure that thing. There was a bleeding there, and then I just change over to my 15 French sheath, put a Terumo wire, came out, leaving a catheter. After 7 days, I could use my same 22 French assembly and complete the enucleation for such a big prostate. So this is unfriendly urethra. Second thing is when you have a large prostate, at times you have a stretched veru. If you look at this, this is the first kind of veru. You can say it's a dual veru, and once again you go inside, you get a second elevation. So at times of enucleation, if you go more proximally, you might leave a lot of prostatic tissue. So you need to understand the veru gets stretched when you are encountering a large prostate. Untoward events of enucleation can be arterial bleeding, sinus bleeding, capsular perf, and subtriangular dissections. Arterial bleeding, yes, see, we are doing very well. There was no bleeding, and the moment I cut that, there was a torrential hemorrhage. And the basic difference between laser and the electrocautery is laser fiber does not have that mechanical ability to compress that bleeder. So at times, even in the cautery loop, is better to control such bleeding. Say I'm struggling here, I'm not been able to control it, but then what we need to do is we need to understand whether I will be dealing arterial or venous, and we always have to make sure this is not a ricochet bleeding. The bleeding comes from the other wall of the prostate, and we keep on looking at the same wall. And if it is not controlled with laser, there is no shame in resorting back to the loop or the roller ball, because it gives us an ability to mechanically compress that. However, in this case, I could manage. I withdrew my fiber a bit and then locate the point source of that particular bleeder and hit it and could achieve hemostasis. But there is no problem. We can always resort to the electrocautery loop. Next is sinus bleeding. This enucleation is crystal clear. We don't see any bleeding. This is the last few bits of enucleation, and that lobe has gone. Crystal clear vision, few twigs here and there, we could hemostase that, and then we can have a very clear vision identifying the ureteric orifices on both the sides, looking at the prostatic lobes, and now we're ready for the morcellation. But the moment I withdrew myself, what I see is there was this kind of bleeding. And when I just deepened my scope, I could see there was a big sinus here. And this sinus bleeding was a problem. With this kind of bleeding, if I pursue for my morcellation, it is going to be very difficult, and I'm inviting more and more nightmares. So what we need to do is, we need to, again, to differentiate whether it is arterial or venous. If it is venous, never try to coagulate. Leave a catheter, traction for 7 minutes, you can resume the procedure. However, there are instances, if it's not getting control, there is no shame in staging the procedure. However, in this case, we left a catheter, keep traction for 7 minutes, and then again resume the procedure. Look, it's a crystal clear vision, and the morcellation procedure went absolutely uneventfully and safely. So these are certain things. One more thing is capsular perforation. Now this happens, it can be either covert or an overt. This is a covert perforation when I was one plane deeper than where I should be. So there was a capsular perforation. We always need to identify that in early. Now there is little more tragic event. This is, like somebody showed us yesterday, bipolar enucleation. There is a mechanical push. The moment you push, there is an uncontrolled force, and you can lift a big perforation. When you encounter this kind of perforation, only God can help us. So what do? Never use blunt force to dissect. We have laser, it's a fantastic energy. We can just lift it with a minimal traction and use the laser fiber to dissect. We need to recognize it early, and we have to just reorient ourselves. We have gone one plane deeper, we have to reorient one plane superficial, and we can convert an overt perforation into a covered perforation. But mind well, whenever you come across such perforation, always ask your anesthetist to keep an eye on the hemodynamics and assistant to titrate the inflow and the outflow, because silently a lot of fluid imbalance can happen. Subtriangle dissection usually happens in a very large median lobe. So here I'm doing terminal enucleation of my median lobe, and where I go, I'm going a little bit down. And this is the subtriangle dissection. Whenever this happens, we need to understand that we need to reorient ourselves. And again, we have to go one plane superficial. We need to leave a sleeve of tissue on that subtriangle area so that, it will be covered. And it can be a covered kind of a subtriangle dissection. So that is the message. We have to anticipate this kind of subtriangle event in large median lobe. We have to mark the capsular fibers right at the beginning and follow them. At times, doing a reverse enucleation, changing the whole orientation into 12 o'clock and enucleating it from above will help us preventing this complication. Coming to the morcellation, this kind of 4 events can happen: floaty cheese balls, bladder injury, morcellation failure, and breakage of morcellation blade. Now this is the floating cheesy ball. Usually this happens at the last. You have done enucleation, consume a lot of adrenaline, now you are doing morcellation, and this last few bit, they just don't get engaged to your blades. It's a really frustrating event because you're all mentally tired. So how to manage? We stop chasing this with the help of morcellation. We simply use a retrieval forceps, take it out, pluck it, and take it out intact. So this is how we can manage. One thing is we can always make sure that we should never chase them. Second thing is a bladder perforation. The same thing happens in the same sequence of event. When you are chasing this floaty cheese balls, you tangle one piece of bladder mucosa there, and without your notice, if you start morcellating, what you come across is this. This is a superficial perforation. Having said that, if you do not recognize it early and you go on morcellating, you can end up in a bigger and a full thickness perforation. So what do we do is, we should never pull. Even if you take a grasp of bladder mucosa, never pull. Turn off the morcellator counter.
We have 2 minutes left,
Yes,
please.
sure, sir. Next 2 slides. And you can detach the suction pipe from the morcellator blade, so it will eliminate the suction, and then you can gently withdraw. It will minimize the bladder injury. Most of the cases, it's inconsequential. You can leave a catheter, it heals up in 48 hours. Now, third is morcellation failure. It can become because of equipment malfunction, blades getting older, a tough prosthetic tissue, or 2 big lobes. And how do we do it? We can use a new set of morcellator blades. We can state the procedure, or we can use Frondorfer's loop to resect these lobes. But having said that, it's very difficult to resect these lobes which are free floating, but you can do that. And the last is breakage of morcellator blade. See, look at this video very carefully. I'm morcellating it very gently, and you can see there is a piece of blade which is coming out on the 11 o'clock. And now I'm rotating it to disengage it from the prosthetic lobe. This is the blade which is there, and now it is fixed with that thing. So what do we do is, we have to identify this, we have to chain the blade, we have to finish the morcellation, complete the procedure, and lastly, we have to seek for that piece of blade. We can retrieve it, and then we have to make sure we don't retrieve it through the urethra. We have to take it inside the sheath, and then we have to take it entirely covered, because if we do it through the urethra, it might injure urethra. So my friends, there are few unwanted sequelae also. Stricture urethra we all know, and this is different way of managing. This is one particular procedure which I'll see between cold knife VIU and laser VIU. Laser VIU always gives you a controlled cut, and this is particular video I wanted to highlight is that we have a very controlled kind of cut, and we can actually do radial cuts, superficial cuts, not giving rise to any spongiofibrosis. And what I am doing is this I conducted on 15th August, our Independence Day, and what I could achieve with the controlled cut was the map of my country, India. So this is what, a controlled kind of, laser gives you. Same thing, lessons learned, we have to minimize the size. This is the conventional 26 French assembly. Now we are doing only the 22 French mini holep. And with that, stricture incidence is decreasing. Bladder neck contracture, again, same. Either we can use a cold knife or we can use laser to cut it. And one interesting video is this. We can actually have no through and through hall across into the bladder. At that particular time, we can't incise. At that time, we have to resect the entire scar. So we can resect the entire scar, and then we can see the bladder opening, and that's how we can go into the bladder. So this is one more way to approach a bladder neck contracture. Lessons are there. We don't enucleate. We just incise. We preserve small mucosal strips at 12 and 6 o'clock. Next is residual adenoma. It's, you can see there is entire right lobe is clear, on the left lobe is there. And this is a new complication because of the new kidney in the block, tooth flap. TFL cuts anywhere, while holmium cuts only if you are in correct plane. So that is precisely why the recent paper says that the learning curve with TFL is far less, and same thing, the residual adenoma rate is far greater with thulmium, because people feel they have done enucleation, but they have not done the enucleation. The reason behind, thulmium can cut through the tissue. Now here my fellow is cutting this, enucleating this lobe, and he is feeling that he is enucleating, but actually he is cutting in between the lobe, and he is leaving lot of tissue, which can lead to residual adenoma. So my take-home message would be, always remember, complications do happen, we have to accept it, and remember this acronym DPT. How early could you detect it? How you could have prevented it? And how best could you tackle it? If you remember this DPT, I think you will be through. Even with complication, you can take a lot of credits. And remember, the only person who never makes a mistake is the person who never did anything. And we learn from our failures, not from our success. But the only real mistake, what we do is when we learn nothing out of that mistake. So we keep on doing complication, and we keep on learning in the betterment of our patients. Thank you so much for the patient listening, and thank you so much for this kind invitation once again. You can find me at this. Thank you so much.
Thank you, Dr. Joshi, for the very nice talk and tips and tricks on how to avoid complications and manage them in HOLIP. We will move to the next speaker for the sake of time, and we will take questions at the end. So next speaker is Professor Hassan Abu Al-Ainain. He is a professor of urology, president of the Egyptian Urological Association, and he is the chairman of the scientific office of the Arab Urology Association. He is a former director and chairman of urology department and of the urology and nephrology center in Mansoura. And he's going to tell us about how to deal with rectal injury during pelvic surgery. Please, Prof. Hassan.
Good morning, everybody. Thank you, Dr. Hussein, for the introduction, and thank you. Greeting from Mansoura, from Egypt. This is Urology Center, and I think some of you have visited this place. It is really a museum of urology. You can see 30 to 40 operations every day if you stay with us. For 1 week, you can see all what you would like to see in urology. The topic is rectal injury during pelvic surgery. And this event is an uncommon, even, but it's even rare, but sometimes it is lethal if it did not recognized early and properly treated. The incidence is decreasing with time. If we compare year after year and decades after decades, it has been declined by 26% over years because of better anatomy, better vision, and better experience. Of course, the overall incidence of rectal injury during pelvic surgery is around 0.5%, and usually in the literature it is underreported in many times. It has been also estimated that using the minimal invasive techniques of robotic intervention with minimal invasive surgeries, it has declined because careful dissection and undervision and good lighting magnification would reduce significantly the incidence of rectal injuries. It was estimated in open surgery up to 1.3%, a little bit less in laparoscopy, and in robotic it is much less. The types of surgery that they may lead to injury of the rectum during dissection includes several interventions: radical prostatectomies, cystectomies, anterior pelvic excenteration, excision of tumor recurrence, posterior diverticulectomy, deep pelvic tumors, some gynecological procedures, perineal urologic approaches, and it depends on the risk factors, including age of the patient, the bulky tumors, locally advanced disease, low volume centers, low experience of the surgeon, previous irradiation of the pelvis, previous prostatic surgery, high Gleason score, lymph node involvement, the positive surgical margin, obesity, previous rectal surgeries, pelvic fracture and trauma, pelvic inflammatory disease, complicated prostatic biopsies, and undiagnosed rectal pathology. All this list of these last two slides include the risk factors of inducing inadvertently rectal injury during dissection. Of course, which is very unique for rectal injury is the previous irradiation of the pelvis, regardless it is irradiation for the prostate or for the bladder or for the cervix. And it increases because of tissue reaction. Incidence is quite a little bit higher, it's up to 15%. Salvage prostatectomy in 300, in almost 400 cases. In open surgery, it reaches up 3%, but it's much lower if you use robotic approach, even in previous irradiation patients. It is due to adhesions and there is no pelvic planes. The fat plane is not existing quite nicely. Ischemic fragile tissues that may be easily injured and perforated even with gentle manipulation. Can we reduce the incidence of rectal injury during pelvic dissection? Yes. But the problem, we don't have any preoperative provocations but which is important, just you have to anticipate or expect that this patient is high risk of rectal injury, and this makes you to be carefully dissecting under vision without heroic surgery. Vigorous heroic surgery, bloody field, blind clamping, cutting, coagulation without seeing exactly may lead to high incidence of injury, and please mind your step. Of course, we can reduce the incidence of rectal injury if you do a careful under vision dissection, use the cold scissor rather than the hot scissors, avoid liberal use of monopolar cautery, follow the perirectal fat plane stepwise, piece by piece, and follow the curve of the sacrum, because sometimes when you go down, you have to move anteriorly more because of the curve of the sacrum. The curve of the rectum is coming anterior, and your instrument is straight. So use curved instruments, either scissor or even clamps, to be away from it. Minimal traction or compression of the rectum against the adhesions. Use a good illumination loop. Of course, avoid the finger dissection, because the finger can perforate even the fragile rectum rather than even the sharp instruments. Consider the anatomy. On lifting the bladder and the prostate anteriorly, there may be tenting of the rectum anteriorly as well. I just make a drawing that the rectum may be pulled up anteriorly in adhesions with the prostate and the seminal vesicles, and this tenting effect is bringing the anterior surface of the rectum into your cutting field. Take care of this and always consider the anatomy in the pelvis before going in down here. Rectal injury, and how to diagnose it. Of course, we can use a sponge stick placed in the rectum to see if it is perforation or not, but which is very practical and easy to use is the pneumatic test. Pneumatic test either to inject an air through a previously fixed rectal tube and irrigate the field by saline solution, inject an air. If any bubbles comes, of course, this is quite sure that there is no injury or there is an injury if bubbles comes. If you don't have a pre-inserted rectal tube, you can just make a proximal squeezing from the distal sigmoid down to the rectum, pushing some air from inside the colon, and you will find the ballooning up of the anterior surface of the rectum. If any bubbles come from this squeezing issue, it would be an hidden perforation. You can look for it. Digital rectal examination if you are suspicious to ensure adequate closure if it has been. Bacterial swab usually identified to select the proper antibiotics later on, and thorough irrigation of the field with antibiotics. Some advice when to close the rectal injury. Shall once you cut it, you close it before finishing the procedure, or you just wait until you finish the dissection and remove the organ up, and then try to have a wider field and better exposure, and then you close it. Some advise that you have to repair it immediately, but I don't agree, because it may recut again while you start going dissection anymore after the suture. Suture should not be touched after it has been fixed, because you have to fix also an interposition of a tissue. Closure in 2 layers using absorbable stitches is mandatory. Endoscopic clips or fibrin glue has been tried, but it is not advisable. Tissue interposition is very, very necessary, either omental flap or interposition of peritoneal flap. This is after closure of the fistula, I have to invite a good piece of omentum to interpose between the closure of the rectal injury and the suturing of the bladder to the urethra or the pouch to the urethra, of course. Is fecal diversion is always needed? The answer is not. It is not routinely recommended in every case during radical surgery. 10% only would need colostomy in the same session. But it is strongly recommended to have immediate stool diversion if the tear is very large and irregular with violated edge, if inadequate closure, thermal injury, radiotherapy, dense adhesions, abscess or infection, or suspected disease infiltration. Of course, the post-operative management is important after you make a quiet closure of this rectal injury. Clear fluids orally in the second or third day, step-by-step soft diet. There's no harsh food is allowed at least for 1 week. Broad-spectrum antibiotics, including anaerobe metronidazole. Longer catheterization time, up to 2 to 3 weeks. Cystogram or pouchogram before catheter removal. Gravity pelvic drain. Some prefer to have a suction, but I don't prefer to have a suction drain. It may invite more persistence of the fistulization. 10% of these patients may end up with fistula, and anal dilatation postoperatively is questionable in this issue. If the injury is undetected during the surgery and has been overlooked, you say that I did very well, I couldn't recognize the tear, but unfortunately it is maybe early or late complication happens. May be fatal even if abdominal pain, systemic infection, and all the inflammatory markers will be high. Abscess, peritonitis, septic shock, especially in the elderly patient.
1 minute
it
left,
may be
Dr.
failed. Okay. Should be suspected early, and the computer tomography is important. There is a staging have been advocated by Martini et al. In 18. Stage 1, if the tear is less than 1.5 centimeters. Stage 2 is more than that, but admit the tip of the finger. Stage 3, if it's associated with violation of the sphincter damage. Treatment of unsuspected rectal injury could be treated conservatively, but very cautiously with antibiotics and observation, of course. But if unfavorable course of that peritonitis, pelvic abscess, you have to immediately explore, and fecal diversion is mandatory with or without closure of the defect. If it is a stage 2, of course, wider undiagnosed tear, immediate exploration with fecal diversion with or without fecal defect. Development of fistula later on may be expected in minority of cases, and York-Masson procedure is the most popular transanal posterior approach, but should be done with expert hands. Of course, this is a way that the fistula could persist after a couple of months, and in this case, you have to have a repair in expert. And take-home message, the algorithm is as we showed in intraoperative detected. Of course, if it is favorable, you can close primarily with interposition, but if it is unfavorable, you can make sure that, and this is also depend on your experience and the surgical needs and the local tissue condition in each case. In case of undetected fecal, rectal injury, of course, if it is stage 1, very conservative, but under keep an eye. Once we have deterioration of the patient, immediately go without any postponing this. In conclusion, it is a rare event, but should be expected more in the vulnerable patient. Should be mentioned in the counseling of the patient that there may be very rare that injury of the rectum, especially in vulnerable patients. The rectum should be thoroughly examined. Robotic surgery has less incidence. Detection is important and the key of success. Undetected injury should be promptly treated once it is expected. Surgical team consultation may be required. In every case, put it in your mind, explain to the patient. Established fistula should be repaired by experienced surgeon, and very rare it may end up with permanent fecal or urinary diversion. Thank you.
Thank you, Professor Hassan. Thank you. So may I invite Dr. Kuram Siddiqui. Dr. Kuram is a consultant urologist at the Sultan Qaboos University, and he is the General Secretary of the Oman Urology Association. He's gonna be talking about primary RBLND is the indication vanishing, right?
Right. And to give some relief to the crowd, this is not a nightmare presentation. It's a success story. So first of all, I would like to thank the organizers, the Arab Association and the Kuwaiti Association for inviting and giving me the opportunity to present. The topic of my presentation is primary retroperitoneal dissection. And the question which arises today in my mind is that, is there a role of urologist in testicular cancer beyond providing just the orchiectomy specimen? As most of our urologists who are more focused in endourology and other lucrative urological subspecialties are kind of, limited to this. The major indication today for retroperitoneal dissections are testicular cancer, in certain cases of upper tract transitional cell carcinoma, in some cases where you have palpable or visible lymph nodes in RCC, and in certain oligometastatic states where, for other diseases. For testicular cancer, the majority of our indication is in the post-chemotherapy area, and there is very limited indication for primary lymph node dissection today. So in early stage germ cell tumor, we all know that in modern medicine, this is a success story of both chemotherapy and surgery. And here, because it is such a successful journey for the patient, that we kind of debate in which cases are we over-treating the patient or are we under-treating the patient. We know that up to 30% of the patients who have early germ cell tumors relapse during the surveillance period. This relapse is generally happening in the retroperitoneum, and this means that the current cross-sectional imaging modalities are not sensitive enough to pick up real disease in the retroperitoneum. Now, what are the limitations here of this cross-sectional image? We rely in CT scan, as we all know, on size only. And in two of these studies, it is very clearly seen that when you do retroperitoneal lymph node dissection and take the pathological specimen, size is not the gold standard only. Those who have used a size criteria of 10 millimeter as a positive for lymph node metastasis, there is a very high sensitivity of about 100%, sensitivity of 37%, but the specificity is very high. Yes, whenever you have a larger lymph node, the likelihood of this being confirmed metastasis is quite high. But when you have less than 10 millimeter lymph nodes, is it always negative? No. If you look at the size criteria of 7 to 8 millimeter, the sensitivity and specificity is about 70% or so. If you further reduce the size of the lymph node as the criteria for taking it as metastatic, the sensitivity improves to more than 90%. However, if you start treating these patients, you will be over-treating a large majority of the patients. So while the consensus is still not there, but we generally presume any lymph node more than 7-8 millimeter in the landing zone especially to be malignant, and then we stage the disease accordingly and manage it. Some of the research has gone into looking at the risk-adapted models to look at the risk of metastasis. The risk factors we all know are lymph node, the lymphovascular invasion, embryonal cell pathology, and invasion of the Retti's testes. Now, if you look at this graph and see that if all the three risk factors are present, all the three pathological risk factors are present in this specimen, namely the embryonal cell pathology, Retti's testes, and the lymphovascular invasion, the risk of having relapse is in the range, the 5-year risk of having a relapse is about 50% or so, which means that there is a large room for improvement still in the area of cross-sectional imaging in this management of this disease. Now, what do the AUA guidelines say? In the stage 1 disease, where the disease is pathologically T1, the preferred treatment option is surveillance. And I think most of us will agree that a single cycle of chemotherapy is only necessary when you seriously doubt that the follow-up may not be kind of, possible. This patient, you cannot ensure the follow-up, so you may kind of, give him one cycle of chemotherapy. And most of us will refrain from doing any surgical procedures in this stage 1 T1, stage 1A disease. However, in stage 1B disease, when there are pathological risk factors, the disease is more in the testes. It is PT2 and beyond. However, there are no lymph node positive as per the criteria of the CT scan. All the three options exist, and they are surveillance, retroperitoneal lymph node dissection, or single course of BEP. In stage 2A disease, where there is node positive, but the node is less than 2 centimeter, RPNLD or chemotherapy, both are equally kind of, recommended. But most of our centers, today it is chemotherapy which kind of, is preferred over surgery. In the higher stage diseases, I think surgery has very limited role. So in early stage disease, what are the pros and cons of surgery and chemotherapy? One situation in which we do a primary lymph node dissection is that if you have N1 disease, observation is still an equally valid option or even a better option than chemotherapy. We all know that retroperitoneal lymph node dissection is very helpful in accurate pathological assessment. It prevents the long-term toxicities of chemotherapy, and surgery may address any chemo-resistant component like a teratoma in the field, which kind of, leads to reduction in potential for somatic malignant transformations. It also simplifies the surveillance protocols. However, this treatment option comes at a cost, and we are all very well aware of the side effects of retroperitoneal lymph node dissection. However, having said that, chemotherapy again is not void of any even long-term or short-term side effects. In this study, which was done, and over 6,000 patients were assessed between the ages of between 1976 and 2007, with a median follow-up of approaching about 15 years, they found that there's a twofold increase of development of secondary malignant neoplasms in patients who received chemotherapy and radiation. So a 25-year cumulative incidence of solid secondary malignant neoplasms is about 10%, and this is not to be ignored. So these side effects are both dependent on the intensity of the chemotherapy, the dose of cisplatin which they receive, as well as the radiation, the dose of radiation which they receive. So this brings me to a very interesting case which we recently managed. This is a 15-year-old boy who presented with 6 months history of right scrotal swelling, had history of left orchidopexy done at around 3 years. His left testes feels softer. The volume of the testes is about 6 ml, 6 milliliters, and there were no other abdominal masses. The tumor markers are as shown, and the CT scan which was done showed that there is about 15 millimeter nodal mass in the area of the aortocaval window. So we did an orchiectomy. It turned out to be pathologically T2. Post-operatively, the beta-HCG reduced, but it was stuck at 20. The semen analysis, which was done on him pre-operatively, showed azoospermia. The FSH is normal. Now, if this patient is subjected to chemotherapy, his chances of fertility in the future are going to be almost 0. So we went ahead and did a nerve-sparing right retroperitoneal lymph node dissection on him. 2 out of the 45 lymph nodes were positive. The beta-HCG normalized. And in this scenario, I think he would be very well managed with observation only. So in certain situations, I will conclude that RPNLD is a valid treatment option. It is the cornerstone in management of germ cell tumor, especially in the post-chemotherapy setting. In salvage situation, I agree that it has a very limited role. Thank you very much.
Thank you for the talk. Now we welcome Dr. Ali Abdul Wahab, who's a specialist in urology at Jabr Hospital, Kuwait. He has a French and European Board of Urology. He has a fellowship in functional pathology and of the pelvis and the perineum in France, robotic and minimally invasive urology surgery fellowship from Canada. He'll talk to us about persistent hematuria.
Thank you, everyone. Good morning, everyone. I would like to thank the Arab Association of Urology and Kuwait Urological Association for this opportunity to talk to you about persistent hematuria. Actually, persistent hematuria is not per se a nightmare for urologists, but maybe a nightmare for the patient. So if we talk about the definition of microscopic hematuria, it's the presence of more than 3 red blood cells per high power field. But when we talk about persistent hematuria, we don't have a consensus about its definition, but according to the American Association of Urology, you have to repeat the urine analysis in 6 months, so we can say that persistent hematuria is having persistent hematuria in more than 6 months. So the clinical significance of microscopic hematuria, as we all know that less than 5% of the patient may represent underlying malignancy, and the problem with, maybe it's related to the education to the medical school students, that we have less than 50% of patients referred to urologists, and even if they reach the office of the urologist, less than 20% may underwent any workup. So for the diagnosis of microhematuria, as I said, that we have more than 3 red blood cells, and the clinician should not define microscopic hematuria by dipstick, but by microscopy alone, because this might, other causes might give a false positive results. So evaluation, as for any patient's history and examination, history of anticoagulation, recent intercourse, sport. We should always emphasize on doing imaging. Ultrasound is primordial in diagnosing most of the cases, and it doesn't cost anything. Maybe we can make some money of doing just office cystoscopy. So for the initial evaluation for the first timer, we have the algorithm of the American Association of Urology. We can stratify our patient low risk, intermediate, high risk. Personally, I just scope every patient comes to my office in order not to miss any patients. And there are many studies that shows that in a retrospective study of more than 10,000 patients with microscopic hematuria, that patients with repeat urine analysis that showed microscopic hematuria are more likely to present a malignancy. So do you do cytology? I was trained in France, and we do cytology for our patients. I always do cytology over a 3-week period, once per week, and during cystoscopy. There is no evidence on that, but I like to do it this way. When doing cystoscopy, the white light cystoscopy, the standard of care, I think Hexvix, white light, blue lights, just adding cost with the low incidence of malignancy in microscopic hematuria, and the logistic comes with it. And narrowband imaging, if you have the setting on your scope, why not? But we don't have any reports in diagnosis of microscopic hematuria, but with patient already diagnosed with a bladder cancer with these 2 techniques. Imaging, I think, as I said before, ultrasound has a very high sensitivity to rule out renal masses, not bladder mass, less for the upper CC, but as we all know, the incidence for the upper tract urothelial carcinoma is very low. I would like to present one case with a 33 years old when I was a chief resident in France, who present many occasions with loin pain, and the left side with gross hematuria. He came to the emergency department with normal blood pressure, non-tender loins, no lower limb edema with the normal creatinine, and the urine analysis. And the next day, when the hematuria result shows no cast or protein, I admitted the patient where his CT KUB was unremarkable. I collected the 20-hour urinary protein, which came back positive, and we have a very competent nephrologist who took a biopsy, which confirmed a medical cause, a nephritic syndrome, in its early stages. The other case was a patient, 71 years old, diabetic hypertensive, history of kidney stones, presented to the ER with one-day history of gross hematuria. He has a big prostate, 80 gram. Systemic analysis showed was unremarkable. The white blood count was normal. Creatinine was in the upper high because of his diabetes hypertension. Urine routine and microscopy showed significant microscopic hematuria. He did a CT KUB, which was his big prostate, and have a small stone in the lower calyx. He was discharged with antibiotics as a diagnosed as a UTI, and fortunately this patient has a friend of mine who was a doctor who referred him to me, and I did a cystoscopy that showed this lesion in the vero of the prostate, and it was resected and came back with a benign pathology. So the take-home message for this talk, always question the possibility of malignancy, always follow your patients, always use your simple screening tool, ultrasound, cystoscopy. Don't assume it's benign unless you rule out malignancy. Don't take it lightly to yourself or for the patient, because these patients always, when they tell them that they have infections, stones, or because of their anticoagulation, they don't come back. And we are urologists, and I think we have a good medical sense. We can always diagnose and surprise other medical professionals in the field. Thank you.
Thank you, Doctor. I would like to thank all the speakers in this session, and we're going to open the floor for questions, if any. Any questions? Okay, thank you.
Dr. Abulanain.
I do have one, actually.
How many of us has been obliged to do emergency cystectomy due to significant bladder perforation, inability to control bleeding? And what can we do? Because I have experience in my life for the last 3,000 cystectomies, 6 times we have been put in this situation, and decision should take out because this significant tumor. It seems muscle invasive from the gross. Of course, we don't have pathology, but it is unquestionable that it is a tumor. But the patient is not counseled to have, but he was in life-threatening injury of the bladder, in addition to horrible bleeding, could not be controlled by the endoscopic maneuvers. Whoever of you did this emergency cystectomy, and what is the outcome?
Legal and regarding medical legality nowadays, to do procedure like this and remove the bladder or do cystectomy, and you have no document that is a malignant tumor.
This is the question, but we have been put in this very strict, narrow decision making, and I can remember he was 23 years old, multicentric, all the bladder is full of papillary tumors, the bladder has been perforated, bleeding come horrible, and you cannot go in between these fronts to coagulate the source of the bleeding. So we just explained the issue to the family, and we took the decision of cystectomy at that time.
How about angioembolization?
I have experience of angioembolization. It is partially improving, but it recurs. The significant improvement doesn't exceed 60% to control the bleeding.
So no doubt the radical emergency cystectomy does play a role, but what you are correctly pointed out is your angioembolization gives you time, gives your patient some time to get better, and then he can withstand that kind of a magnitude of surgery in those emergency conditions better. So that is what the role angioembolization plays. Even if it doesn't settle down completely, it gives you time to build the patient up.
Yeah, good, yeah. Actually, I have a question, maybe it's just a quick question about your experience in patients with perforation during TURBT. Have you seen or let's say, long-term outcome, the risk of seeding in the peritoneum, retroperitoneum? What do you expect later? What shall I expect?
It was a very interesting point at SILS, but we give a prophylactic post-operative adjuvant therapy, assuming that the injury has been the cause of dissemination of some unrecognized malignant cells. But with these two protocol of 2 cycles of systemic chemotherapy and longitudinal follow-up of these patients, we don't have any recurrence, neither distant or local, in these 6 patients.
So you mean systematic chemotherapy?
Yeah, systemic.
Okay, because
Systemic because the bladder has gone.
okay.
I have experience with 2 cases, like what Dr. Hassan said. The first one was with my colleague who has extensive bladder perforation, necessitating the patient to be admitted to the ICU because of hemodynamic instability. We actually proceeded for cystectomy 3 days later. After proper counseling, and even the patient was still unconscious, we did the cystectomy 3 days later. And fortunately enough, he is okay, and there was no incidence of tumor recurrence. The case I presented, presented with bladder perforation, and we found that we did not immediate cystectomy, I mean early cystectomy within a couple of weeks, and after the cystectomy, unfortunately, he developed local recurrence. So actually, the perforation during TURBT might be catastrophic, more than we expect.
So, yeah. Dr. Haraz, my question to you, because we saw that in one of your videos you had a perforation and you actually opted to change the source of energy. Instead of using the loop, you used the laser. But what about the irrigation which is going out? Would you have, like, thinking now, would you have another decision of like stopping and restaging and doing this tumor in a later stage, or you think you will continue?
Yeah, this is actually a very good question. The first thing is that the perforation was not significant perforation from my point of view, because it's only with the loop and it was on the lateral wall. So even if there is some extravasation, it will be retroperitoneally, not transperitoneally. It deems for me because the bladder didn't collapse during the procedure, so this might be incomplete perforation. And there was a tumor in front of me. So I opted for proceeding with low irrigation, and the bladder is a little bit collapsed, low pressure, and he did well, and this was a superficial bladder tumor, non-muscle invasive disease, and he didn't develop recurrence. It's like 2 years ago.
But the concern here is, again, fortunately this patient did not develop recurrence, but we're talking about seeding. We're not talking about, I know it's retroperitoneal probably, and it's not intraperitoneal, patient is stable, everything is fine, but it's different than the prostate. I think with Dr. Joshi, he showed us that in HOLIB, you can actually tolerate having a small perforation in the prostate capsule, and you can continue. You can finish your HOLIB without any complication, and you can remove your catheter 1 or 2 days post-operative without any further sequelae. However, if you have a big perforation and patient is unstable, as Dr. Joshi mentioned, at that time you stop and you stage your procedure. But in TURBT, you're talking about tumors, so you're actually concerned about seeding again, as Dr. Faraj and Dr. Hassan Bulainain were mentioning. So I don't know, yeah, would you advise anything else?
When we go to the literature, we don't find a protocol. No, there is no protocol for this. Because, yes, there is under-reporting of this complication. So every case should be individualized according to the experience, according to the situation, the size, the size of perforation. So there is no clear way to do this.
I think keeping the tumor, not resecting the tumor in this case of perforation, with the minimal perforation, will increase the risk of seeding. If you remove it, you'll minimize the risk of seeding.
Now the point is, that patient already underwent a TURBT and he was referred to him for the second look. So when we are doing a second look, we are actually doing it for the sake of, identifying those missed tumor and getting a base resected. There was not an emergency. There was no bleeding. It was a planned surgery. So I personally feel the message we should give the delegates is that in such a condition, even if trivial perforation is there, we can always stage that kind of a planned second look resection. Would it have been a bleeding tumor, we might have gone ahead and done it. But with this kind of a settled patient, a settled disease, doing a second look procedure, we should have deferred it.
Yeah.
That's my take, sir.
Dr. Bulbul?
The low-grade tumor, no problems. But we've reviewed a series 40 years ago. The trend was in Lebanon, at least, to open patients and do resections, open resections, cystotomy, and excise the tumor. I reviewed, that was around 40 years ago. And I reviewed this series. None of the low-grade recurred. All the high-grade recurred. So if you have high-grade disease, so that's where the issue is. If you have a perforation, you need to open, you excise the tumor. And it's low grade, you're fine. If high grade, you have to decision. So that's for seeding. So high grades will seed in the scar and maybe in the scar of the open, the abdominal wall. Two things, there's no harm in delayed cystectomy, as was mentioned, except if you have a bleeding scenario where you really have to save the patient's life. You can, if you have an intraperitoneal perforation, excise wherever you excise actually that big tumor, close it, talk to the family, come a day or two later after you have talked to them and do the cystectomy. You don't have, it's not an it's very urgent, but it's not an emergency or life-threatening.
Exactly. So intraoperative, the patient would have, like the bleeding would have been really very severe in order to put the patient in instability in order to take a decision of doing an emergency cystectomy. And at that time, you're justified because you're saving the patient's life. But this scenario is probably a very, 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 very rare scenario to happen, right? Dr. Musa?
Yeah, I have a funny case. It takes about 3-4 minutes to tell it. You want to hear it? It's about emergency cystectomy. This is a patient around 55 years old. He came on a Friday at 1 o'clock, Friday, and it was Ramadan. And he has severe bleeding and clotting in the bladder with urinary retention. He brought a CT scan with him. He is having atrophic right kidney, distal right ureter tumor, and the bladder is full of clots. And his son, he told me from Ja'far, Beit Ja'far from Akkar, from the north, from Lebanon. They are very difficult patients. And he told me maybe you can do him a cystoscopy and you can make him declotting and we will end with it. Okay, I told him, yes, we'll go to the OR. We were at 1 o'clock. At 3 o'clock, we went to the OR. I put the cystoscope inside, and it came bleeding. It started to bleed. It didn't stop. I didn't see anything. Then I put a catheter, I put irrigation, I put him to the recovery, and the anesthetist, he was a very not so fit anesthetist. He was very afraid. I told him, we are losing him. What should we do? What you have to do at this case, you don't have a radiologist for embolization. You have you and the anesthetist in Ramadan, they don't want to work. And I went out, I told the family, we have to remove the bladder. We are he will die if we not remove it. And then they told me, no, we have to wait for his children to come from the north. We will wait until tomorrow. Keep the foley and put him on the floor. I told him it will not work. We have started to give him blood. Then I decided. I took him in the OR and I made a cystectomy. And then I've seen the ureter. There were the whole ureter, the distal part was also with a tumor. What you should do with the atrophic kidney. And I told I will remove the kidney also. And we went up. I removed the kidney and I put a ureterocutaneostomy from the left side. And he went on the floor. And the second day, they came the parents and they made a big theater. How could you remove the bladder? I told him that it's not only the bladder, the right kidney also. What, the right kidney? And then the cost of the surgery. They told me we will not pay anything. I told the administration I will pay everything. And then it was a Saturday. And Saturday, there are patients, we will treat them with the Ministry of Health cost. And exceptionally, the doctors from the Ministry of Health, he came, and I told him the case, and he told he will take all the cost. And this was my case.
Thank you for sharing that with us, Dr. Musa. One question to Dr. Joshi. We see that you use in Holib, use the 22 French what's called mini Holib set. how's your experience with that? And are you doing all cases with this set?
This is the second generation of mini HOLEP assembly. Firstly, we had the mini HOLEP wherein we could enucleate with the 22 French assembly set, but still we didn't have a morcelloscope which will allow the morcellar blade. Now, for last 1 year, we are having even the morcelloscope which is passing through the 22 French. So now it's a complete second generation. We call it a slim flap. Now, after using the slim flap for last 1 year, the stricture rate has gone down significantly. Even the transient incontinence rate also has gone down significantly. And many times we see that with that particular assembly, I have conducted a study, the irrigation flow, the vision, everything is at par with the 26 French assembly. And most of Indian urethra, they are not accommodative. So now we are seeing that we don't have to defer any surgery because of the larger sheath. And we are primarily being able to conduct all the HOLEP with a significantly decreased stricture rate as well as incontinence rate.
Great. Do you have the 18 French?
No, 18 French assembly is not there because 22 French, 19 French inner assembly. So you can still go down to 19 French, but with 19 French, will not have continuous flow. We'll have an intermittent kind of, irrigation. So it will not work for a very large prostate.
Great. Okay.
Thank you.
Thank you very much for the speakers and for our co-moderators here and the other, and we'll move to the next session. Thank you.